My name is Robert Ye. I'm a cardiovascular outcomes investigator and an interventional cardiologist, and I'm really incredibly excited to be joining the staff here at Beth Israel Deaconess, and really tremendously excited about this one opportunity, which is creating something that we're calling the Smith Center for Outcomes Research in Cardiology. The Smith Center is going to be a place where we bring the most rigorous scientific and analytical methods to the study of data, clinical trials, electronic health record data, in order to understand how we can best improve the value of the health care that we deliver, especially in cardiovascular care. Right now we're at really a historic moment in healthcare delivery. We have an incredible array, an arsenal of medications and therapies and devices that we can deliver to patients. At the same time, patients are becoming much more complex than they were historically, in part because the population is aging, and we've put off diseases and treated a lot of acute diseases such that really what remains is many chronic diseases. As a result of that, there is really an unparalleled need now to really understand who are the specific patients that benefit from the particular therapies that we can offer them, and who are the patients who maybe won't benefit from those therapies. In addition, because of rising healthcare costs, it's critically important that we get this right so we can produce health in a population in a very sustainable economic way. One of the first questions that we're going to look at, or we are in the process of examining, is what has been the impact of the Affordable Care Act on readmissions. So readmissions after hospitalizations within 30 days of a hospitalization are extremely common, it turns out, and a source of really high costs to the healthcare system. It's something that the administration was really focusing on. The Center for Medicare and Medicaid Services was quite focused on, because it looked like it was going to be a source of preventable healthcare expenditures. So in 2010, with the Affordable Care Act, a law was passed such that those hospitals with the highest readmission rates were actually financially penalized for these readmission rates. It was really one of the first examples of using an outcome to actually of a hospital to influence the payment that that hospital receives, really pay for performance at the hospital level. There have been some concerns, however, that penalizing hospitals by withholding money, especially those hospitals in the greatest need, might actually worsen their ability to reduce readmissions. And so what we're looking at right now is what did happen to readmission rates in hospitals from 2010 onwards. And in particular, for those hospitals that were penalized the most, did they respond by improving the most, or was it in fact sort of a regressive penalty such that they weren't given the resources that they needed to improve, and that could potentially exacerbate disparities? That's really one of the first primary question that we're working on actively right now. Beyond health policy, we're also looking at comparative effectiveness research. So what are the therapies we use in practice? How do they compare in terms of the outcomes that they provide to patients relative to their alternatives? How do they compare relative to the costs that they are associated with? So that's the second area. And the third area, which I think is really the most exciting, is how do we use new sources of information? Some of the information that we already use is stuff that comes in through the electronic medical record, but there are ways to capture more information from the electronic medical record, reading in between the lines, so to speak, using natural language processing. And there's even more data that patients themselves can provide, whether they're in terms of how they're feeling, their symptoms, and even something that's growing in importance, monitoring devices, wearable technologies that will allow these data that patients can provide and allow us to analyze and understand really better how they're feeling and how they're doing. The overarching goal is really to take the methods that and critical questions, combine those with rigorous analytical methods and the new sources of data to answer questions and provide solutions that really answer questions in the most pressing issues of cardiovascular care. And I think ultimately, if we can identify better ways to treat patients, if we can improve quality, improve value, individualize therapy, that's going to lead to longer and healthier lives for patients.